My name is Michael Betel, and I'm the president and founder of the Fatty Liver Alliance. Today, I want to welcome two incredible guests and a brand new topic to discuss. Mark Swain, hepatologist and professor of medicine from the University of Calgary in Alberta, Canada, and Mazen Noureddin, who was the founding director of the Fatty Liver Program at Cedars-Sinai Medical Center. He recently relocated to Texas from California to establish a state-of-the-art Houston Research Institute. He's an expert in non-invasive testing and biomarkers of NASH and cirrhosis. Mazen, you recently published a very important and insightful paper about machine learning and the ability to predict severe liver disease. This is incredible, and many would say breakthrough. What's machine learning, and how can it help us with identifying patients who have severe liver disease and the risks for progression?
Thank you, Michael. It's great to be here with you and friends. And I'm glad that you like this paper. We started thinking about it actually a couple of years ago, especially in the field of hepatology. You have seen machine learning and the AI technologies in other fields, and in the field of hepatology, mainly in pathology, which is great to have. But also machine learning can do multiple things, and one of them is disease prediction. And that's what we did. We had a very large cohort, or we collected a very large cohort of patients, 1,300 with paired biopsy. So this is actually one of the largest cohort out there with paired biopsy within the 6 months. It was just a collection of multiple medical centers that we put in one pod. And to answer your question, as I start, before I go into details, it's the computers and softwares and machine learning and AI, what they do is they go and see your data and start analyzing it. And the way I want to put it is they're smart ways to make things perfect in terms of prediction. And that's why a lot of times, which happened in this paper and some New England journals paper, you don't see the testing cohort, you just see the validation cohort. The reason why you don't see the testing cohort, because what machine learnings do, if they want to predict, let's say, F2 patients, and the testing cohort, the area under the curve can go as close to 1, because the softwares are seeing all variables and seeing the outcome and just do kind of like this first look and make it as perfect as possible. And then you go validate it in a subsequent test, which is the validation test, and you look at your area under the curve, sensitivity, specificity, MPV, PPV. So yeah, that was an effort to, now we have multiple non-invasive testing, but the question was simple. Can we take the patient's variables and do as well as FIB4, FibroScan, that's what we had in the cohort, or do even better because of this ability for the machines that is close to perfection nowadays.
I think your hypothesis was as bold as to say that it could possibly replace biopsy too, right?
I mean, yeah, it's a biopsy is the bad guy. Everyone can criticize biopsy, and poor biopsy, you win at the end. But no, I mean, listen, like I was trained by pathologist David Kleiner in particular, and I still think it has a great role here and there. We just want to go past the biopsy once we can, in a disease that's so prevalent in the world that it's probably incorrect to do it on that many people, especially like when you start talking about follow-ups over years. So yeah, it did better than biopsy, and we're happy to go to more details, and did better than non-invasive testings as well.
Well, I was wondering too, I'm sure Mark has questions he's busting to ask you as well, but is this something that's ready for use in the in the physician world? Is it still early?
It's interesting you asked this. So one of the things that I guess people have to have a little bit futuristic look. the machine learnings the model that we came out had 17 variables. So the nice thing about these 17 variables that they are all available in clinic, that they're routinely done. And we get a comment from one of the reviewers like 17 variables, what do I do with it? Although this is what we think the future with machine learning, you're not supposed to do it. Neither Michael nor Mark just start punching 17 variables numbers, spits out the number at the end. This is supposed to be in another machine, meaning apps. Or Epic, for instance, they should spit it out for you and tell you the risk and the score, and that's where we see it going. So yeah, there are steps being taken now to apply it in certain applications, certain apps, but it will be in a large health system as well as a big app that can come to your clinic and do it for you. Don't forget, it has all the predictions that imaging machine do, not your regular non-invasive testing. For instance, F2 and I'm sorry, FIB4 and NAFLD fibrosis score, technically they test F3 and higher. That's what they do. ELF does test 2 cutoffs, one predicts cirrhosis, one predicts decompensation, versus FibroScan, for instance, will test F0 through F4, and with the FAST score, you will test NASH and F2. These models we have, they tested F2, F3, and F4, as well as NASH and F2 and higher, which is the group that they're going to have therapies at the end, and predicted all of them well and better than the FIB4 NAFLD fibrosis score and the FAST score. And the area under the curve was 0.86 for F2, 0.89 for F3, I think, 0.89 for cirrhosis, and 0.8 for NASH and FAST, NASH and F2 and higher.